You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
What is schizoaffective disorder? Think of it as schizophrenia plus a mood disorder living under the same roof. They both show up and both stick around. Schizoaffective disorder, SAD, equals psychotic symptoms, hallucinations, delusions, disorganized thinking, plus major mood episodes, mania, depression, or both, occurring together over the course of the illness. 2 subtypes. Know these cold. Subtype what it looks like. Memory trick, bipolar. Type psychosis plus manic episodes, plus or minus depression, SAD-B equals bipolar features on board, depressive type psychosis plus depressive episodes only, no mania ever. SAD-D equals depression only, no mania. The diagnostic key. What makes SAD different? This is the #1 tested concept. SAD sits between schizophrenia and mood disorders. The diagnosis hinges on 2 critical rules. Rule 1, the 2-week psychosis alone. Rule, psychotic symptoms must exist for at least 2 weeks, without any mood. Episode at some point during the illness. This separates SAD from bipolar disorder or depression with psychotic features, where psychosis only happens during mood episodes. Rule 2, the majority of time. Rule, mood episodes must be present for the majority of the total illness duration, active plus residual periods. This separates SAD from schizophrenia, where mood symptoms are brief or absent. Memory device, the sad sandwich. Imagine a sandwich. The bread equals mood episodes. They cover most of the sandwich, majority of illness. The filling equals psychosis. It's always there and it sticks out at least 2 weeks beyond the bread on each side. If the bread covers everything, then it's a mood disorder with psychotic features. If there's barely any bread, then it's schizophrenia. If the bread covers most, but the filling sticks out, it's schizoaffective disorder. Quick epidemiology facts. Prevalence, 0.3 to 0.8%, about 1/3 as common as schizophrenia, more common in women. Onset, early adulthood. Prognosis, intermediate, better than schizophrenia, worse than pure mood disorders. Time spent ill, approximately 83% of follow-up time in some form of illness, mostly psychotic states plus subsyndromal depression. Memory trick, SAD is in the middle. Middle prevalence, middle prognosis, middle of the diagnostic spectrum, pharmacological treatment. The golden rule, you must treat both domains, psychosis and mood, acute treatment. Antipsychotics are the foundation. Most patients present acutely with prominent psychosis. Star players with actual SAD-specific evidence, paliperidone, oral ER and LAI. Best studied specifically in SAD risperidone, controlled trial data for both psychotic and affective symptoms in SAD clozapine, the rescue drug for treatment refractory cases. Best long-term, real-world outcomes. Subtype guided treatment cheat sheet, subtype first-line combo. Think of it as bipolar type atypical antipsychotic plus mood stabilizer, lithium valproate carbamazepine. Treating it like bipolar plus psychosis, depressive type, atypical antipsychotic plus antidepressant, SSRI preferred, or plus mood stabilizer. Treating it like depression plus psychosis, refractory clozapine trial. Consider ECT when nothing else works leads to clozapine or zap it. Maintenance treatment. 4 key points. Combo beats mono. Antipsychotic plus mood stabilizer decreases psychosis hospitalization risk, HR 0.76 to 0.84, compared to antipsychotic alone, LA is your friend. Long-acting injectables, especially paliperidone LAI, improve adherence and long-term outcomes. Antipsychotic monotherapy is not enough. Naturalistic data show it doesn't outperform combination approaches. Benzodiazepines equals caution, associated with increased risk of psychosis, hospitalization, long-term memory trick for maintenance. CLCB. Combination therapy, greater than monotherapy, LAIS, improve adherence. Clozapine for refractory benzos equals bad news. Long-term psychosocial treatments. The other half of care medications alone aren't enough. These are largely borrowed from the schizophrenia evidence base. Intervention, what it does, remember it as CBT for psychosis. CBTP reduces positive/negative symptoms plus functional decline. Talk down the voices. Family psychoeducation teaches families to support recovery plus improves adherence. Educate the village. Social skills training builds interpersonal plus practical life skills. Practice being human. Supported employment/education helps achieve work/school goals. Get back to life. Illness self-management promotes recovery plus med adherence. Own your illness. Mindfulness/acceptance therapies reduces hospitalization plus psychotic/depressive symptoms. Be present, not psychotic. Key point: psychoeducation for patients and caregivers is critical in maintenance. Adherence equals everything. Predictors of poor outcome. Know these for exams. Poor premorbid functioning, wasn't doing well before illness. Persistent psychotic symptoms. Early onset family history of schizophrenia. Memory trick, PPEF equals poor premorbid. Persistent.
Thanks for watching. Like and subscribe for more content.